All right. Bonjour, relatives, and welcome to today's session. My name is Misha Leffler, and I am the Cancer Equity Coordinator for the American Indian Cancer Foundation. I am an enrolled member of the Bay Mills Ojibwe Indian community in the Upper Peninsula of Michigan. Miigwech, thank you for joining us for today's webinar. This month is Lung Cancer Awareness Month. Lung cancer is the leading cause of cancer death among American Indian and Alaska Native men and women. Today we are presenting this webinar entitled American Indian and Alaska Native Lung Cancer Data Brief with epidemiologist Melissa Jim. Melissa Jim is a Master of Public Health graduate and is Diné. She is an epidemiologist in the Cancer Surveillance Branch at Centers for Disease Control and Prevention's Division of Cancer Prevention and Control. She has been with the Cancer Surveillance Branch for over 15 years, working in collaboration with the Indian Health Services Division of Epidemiology and Disease Prevention in Albuquerque, New Mexico. Prior to the CDC, she worked at the New Mexico Tumor Registry. Before we get started, I just want to note that hopefully you can type questions into the question box. And let me know if you can't. Otherwise, I would like to turn this presentation over to Melissa. Melissa, thank you for joining us.
Oh, thank you. I guess I should take my little sticker off my video cam. Hi, everybody. My name is Melissa Jim. I'm going to be sharing a PowerPoint presentation once I get it started. Okay, can everybody see the slides?
I can, yeah.
Okay. So I'm going to be providing a short update on lung cancer in American Indian Alaska Natives. First of all, to start off, we'll be talking about cancer surveillance in the U.S. We have three main data sources that we use to create the United States cancer statistics data. It's the official federal cancer statistics. Here it shows that we've got two programs of cancer registries that are funded in the U.S. The first program is CDC's National Program of Cancer Registries. These are indicated by the states that are in the darker blue. And then the other program, which has been around since 1976, I believe, is the SEER program, which is funded by the National Cancer Institute. And these registries are identified in the light green. But we also have some registries that are funded by both cancer registries. And these are the CDC and MPCR registries, and they're indicated by the light green. So they receive funding from both programs. And in order to get 100% coverage of the US population, we have to combine data from both of the programs in order to get a good look at what cancer incidence is in the US. Now, a further thing that we do for trying to correct for racial misclassification of American Indian Alaska Natives in the registries is to link the cancer records with administration records from IHS. Again, trying to identify AIN cases that were misclassified as non-native in the cancer registry. And these results are captured in an IHS link variable in the NACER layout. NACER stands for the North American Association of Central Cancer Registries. And within that, every registry in North America uses this data layout. And the IHS link variable is item number 192. So you literally could go to any cancer registry in the US and ask for IHS link or item number 192, and they would have that field that they could share with you. This is a picture that shows the schedule that we do the IHS linkage. All the states that are in blue are the registries that we link every year, and the states that are in green are registries that we link every 5 years. And this is because the registries in green do not have at least one purchase referred care delivery area county in their state. And I'm currently working on these linkages now, so usually November, nobody might ever hear from me, and that's because we have a tight deadline to try to get these linkages done before Thanksgiving. so that the registries can submit their data to NACER and usually NPCR, but we had a delay in our data submission. So there's a little bit of time for the NPCR registry. Now this slide shows you how we typically stratify our data. This map is from our AIAN cancer supplement that was published way back in 2007, I believe, and it contains data from 1999 to 2004. So here, instead of presenting data by the IHS administrative areas, we actually are presenting data by IHS region. And that's because these fall along state lines, so they're easier for us to use, and they're aggregated in bigger regions, which reduces the small count issues that we sometimes run into with AIN data. The states that are in orange are the states that were included for this cancer supplement. The states that are in yellow are states that were excluded, either by choice or they opted out. And the counties are the smaller designations within each state. The ones that are red are the counties that were included. The ones that are yellow are the ones that were not included for the supplement. And the reason why I'm showing you this is because I wanted to show you the results from the very first linkage that we ever did. This was from the 2006 data submission, the very first time we officially did the IHS linkage. The bars in blue show you the number of individuals that were identified by the AIN cancer registries prior to the IHS linkage, and the bars in green indicate the number of individuals that were identified as AIN based on their linkage to IHS, but were not identified as native by the cancer registry. So these were the folks that were misclassified. And you'll see that for the Southern Plains, there were 3,310 individuals that were not identified as AIN by the cancer registries, but they did link to IHS. And then Pacific Coast, 2,402, Alaska, 70, which actually seems like a small number, but the reason why that is because NCI funds the Alaska Native Tumor Registry. So their job is to collect the Alaska Native cancer cases in their state. So I'm pretty sure that those 70 people that we identified as AIN but were not identified by the registry are folks that were American Indians who now reside in Alaska and were diagnosed with cancer. And in the Southwest, you'll see the misclassification is really low there too, and that is because the New Mexico Tumor Registry actually gets special funding from NCI to collect American Indian cases in Arizona too. So they do their own type of internal IHS linkage before we do this formal IHS linkage. So there's the reason why those two regions have lower misclassification than the other states. Now this slide shows you what happens to the cancer rates, even though are based on misclassification. So you'll see that prior to the linkage, almost every state in the blue, except for Alaska, had cancer incidence rates that were lower than the US non-Hispanic white rate, which is in red. After we incorporated the individuals that were misidentified, it turns out, based on the green bar, that the incidence rates were actually higher than the US non-Hispanic white rate for the Northern Plains and Southern Plains. So it gives us a better picture of what's going on when we try to correct for racial misclassification. And the reason why I'm showing these old results is because since then, a lot of the registries have started changing their race data based on the IHS linkage because they know that their race data isn't good for American Indian Alaska Natives. So if we try to do this snapshot now, everybody will look like they're doing really good on classifying race. This slide shows you the USGS data visualization tool. This is a website that we came out with to try to provide everybody with more accurate data, more timely. The general USGS USGS data visualization tool opens to the states or the US map where you can click on a state and it drills down to the cancer incidence for each state. But a lot of those numbers, when you look at it by state, are the AIN data is suppressed because of small counts. So what we did is we uploaded what we call the American Indian Alaska Native Cancer Incidence Database data within USGS's data visualization tool. And to access that data, you have to go to the More Topics tab, which I indicated here with the red circle. And then once you click on that tab, you go to choose data set, and from the drop-down menu, you select AIN restricted to PRSDA only. Again, PRSDA is the Purchase Referred Care Delivery Area counties in which IHS is supposed to provide services. So those are all the counties that you see in the darker blue on this map. And you also have the option to specify which IHS region you're interested in and the cancer type. This is just the page that opens once you first select AIN restricted to PRSDA only. So it shows you the rates of new cancers by leading cancer sites for American Alaska Natives in this one graph, and then US non-Hispanic white on this side. And when you scroll down, you get cancer rates by IHS region. So if you change the cancer type to another cancer, it would basically gray out all these bars except for the cancer you selected. And then this table right here would modify for that cancer type. So it would show you the cancer incidence for whichever cancer you were interested in for each IHS region. It's a nifty little tool. I encourage everybody to check it out. This is a table that I got from this website, and actually there's a couple of nice features. So for this table, what you could do is export out the data or export out the chart. And what I did was export out the chart, and this is what it gave me. So it allows you to pull data that you could use in PowerPoint. And this just shows you the cancer incidence rates for all sites by IHS region. And I inserted the red bar or the red dash bar, and that just indicates what the US rates are for non-Hispanic whites. And again, like our first slide, we know that the rates for Alaska, Northern Plains, and Southern Plains for all cancers is higher than the US non-Hispanic white rate. Now this shows you the leading cancers for American Indian Alaska Native males and females by IHS region. It's a very busy slide, but basically why I wanted to show you this is because to show you that there are regional differences for some of the cancers. From the slide, we can see for Northern Plains, Alaska, Southern Plains, Pacific Coast, and the East, that lung cancer is the third most common cancer for all those regions. But in the Southwest, lung cancer is the sixth most common cancer for that region. There's a lot of other data here. These numbers under the cancer site are the rate ratios. So what this one is saying is that lung cancer for American Indian Alaska Natives in Northern Plains is 1.8 times higher than lung cancer rates for non-Hispanic whites in the Northern Plains. And then the little number next to the cancer site indicates the non-Hispanic white ranking. So some of the ones that are a little bit more striking are like kidney. For AIN and Northern Plains, it's the fifth leading cause of cancer, but for non-Hispanic white, it's the ninth. So just trying to give you an idea what this graph is showing. This next one is leading cancers for AIN males. So here you'll see that for Northern Plains, Alaska, and Southern Plains, it is the most common type of cancer among males there. In Pacific Coast and East, it's the second leading cause or second leading cancer. For the Southwest, it's the fifth leading cancer. And when you group all the regions together for the US, it's the second leading cause or second leading cancer. This is for females. So there's a little bit more variation here. Northern Plains, Southern Plains, Pacific Coast, and East, it's the second leading cancer, but for Alaska, it's the third. For the Southwest, it's the sixth. And then next, I believe on last Thursday, we released this USGS data brief on lung cancer incidence in American and Alaska Natives, focusing on the U.S. PRISDA counties for 2012 and 2016. I put a link down here to show you where you can find this information. And this is just data from the data brief. So this shows you the proportion of lung cancer cases by age at diagnosis and race. And we've got two different pie charts. The one on the left is for AIN, the one on the right are for non-Hispanic white. And basically what this tells us is that lung cancer tends to be diagnosed at a younger age among AIN than non-Hispanic whites. And 23% of lung cancer among AIN were diagnosed before the age of 60, compared to only 16% among non-Hispanic whites. This slide shows you the lung cancer incidence rates by race, sex, and IHS region. So the graph on the left shows you the lung cancer rates for males. The one on the right shows you the lung cancer rates for females. The blue bar is for AIN. The purple bar is for non-Hispanic white. So here you can see, like, for almost every region except for the East and the Southwest, that the AIN lung cancer incidence rates are higher than non-Hispanic white rates for males. And I think the same patterns for females. This is some of our trends data that we were able to pull out from 1999 to 2006. This is for males. The blue bar is for AIN, and the purple bar is for non-Hispanic white. So you can see that the non-Hispanic white lung cancer incidence rates are decreasing and statistically significantly decreasing. Whereas the AIN lung cancer incidence rates for males increases from like 1990 to 2004, but it's not statistically significant, and then starts decreasing from 2004 to 2014. Again, not statistically significant, and then there's this big drop from 2014 to 2016, but it's not significant. So we need a little bit more data to figure out what's going on here. I think the last time we published data was up till 2009, and it looked like it was decreasing. I think based on a couple more years, we can see that it appears to be decreasing, but unfortunately, it's not statistically significant. And this is the trend line for female. So for non-Hispanic white, there was a significant increase in lung cancer incidence rates until 2008, or until 2006, and then a decrease. For AIN females, there was a statistically significant increase in lung cancer incidence rates until 2008. And now it appears to be decreasing, but that trend is not statistically significant right now. So that's all I have. Does anybody have any questions?
Yeah, we have one question. It says, in the data you are presenting, is there a way to look at people who identify as American Indian, Alaska Native, and Hispanic, or people who identify as multiracial when one of the races is American Indian and Alaska Native?
So the way that we put our data together is based on the way SEER creates their race group code. The way SEER does it is if any of the 5 races, we have 5 races, if any of the 5 races are a minority race, that becomes the race for that person. So if somebody chooses 2 races, say one is white and one is black, their race recode would become Black. But if somebody was Black or American and Alaska Native, I'm actually not sure which one they would code as their race. But we do incorporate multiple races. And the folks that get recoded based on the IHS link are only individuals that were identified as white, unknown, or other. So those are the only folks who get recoded to AIN if they link to IHS. And this is because we have to follow it the way SEER creates the race recode.
Sure. We have another question, and it says, do we know why there's an increase in lung cancer?
Not that I know of. I would think it would have to relate to the increase in smoking, but I don't have that data right now.
Sure.
We are working on a lung cancer paper, but we haven't quite started, so we'll have a little bit more information down the line then. I think the last time we published anything for lung cancer was data only up to 2009.
Okay, we will be on the lookout for that paper then. It looks like there are no more questions. Thank you all for asking questions. I did want to just say thank you again to Melissa for providing us with this information. We greatly appreciate the work that you do throughout Indian country. As far as ACAF and any wrap-up information, we'll be sending a follow-up email with an evaluation survey that we would love for you to complete, as well as a link for the CDC data brief. Thank you to everyone who participated in today's webinar. We hope to see you again on Thursday, November 21st from 2 to 3 p.m. Central Standard Time for the Policy Systems and Environmental Changes for E-Cigarettes and Tribal Communities webinar that we are co-hosting with National Native Network. Please contact me if you have any questions about the information shared today, future webinars, or if you are interested in getting involved with ACAF during Lung Cancer Awareness Month. Thank you again, Melissa. Thank you to all those who participated in today's webinar. Have a great rest of your day.
You too. Bye.
Bye.